Hello, and welcome to Making the Rounds, a podcast by the American Medical Association. Today's episode is part of our Health IT series from the AMA Medical Student Section Committee on Health Information Technology. My name is Christopher Jackson, and I am a medical student at the University of Toledo's College of Medicine, and I'll be your host for today. Today we're joined by Dr. Sally Baxter, an assistant professor of ophthalmology and biomedical informatics at the University of California, San Diego. Hello and welcome, Dr. Baxter.
Thank you so much for the introduction, Chris, and thanks for inviting me to be here. I'm so happy to be here speaking with you.
Oh, it's great to have you on. So just to get us started, for people who don't know who you are and aren't familiar with your work, how are you involved in health IT and what are you currently working on?
Sure. So like you said, my name is Sally Baxter. I'm a physician scientist, which means that I do clinical care of patients. And my area is comprehensive ophthalmology, but also research and operational work in biomedical and clinical informatics. So I kind of took a little bit of an atypical pathway. And after I finished my clinical residency training in ophthalmology, I went on to do a postdoctoral fellowship in biomedical informatics funded by the National Library of Medicine. And so during that time, I had training in a wide array of topics in informatics. And really, that was when I had a foundation in the field and was interested in making that part of my future career. And so now I wear many hats, as a faculty member at UCSD. As I said, I'm a practicing clinician and I see patients and I do surgery. But on the informatics side, I have experience in applied clinical informatics and am actually board certified in clinical informatics, which was a path that I didn't know about until I went through my fellowship. But as part of that, I work with our informatics medical directors at UCSD on various projects related to our electronic health record system and our clinical information systems in general. So because my background is in ophthalmology, I'm sort of the clinical informatics lead for ophthalmology at UCSD. I work closely with our electronic health record analysts, with our chief medical information officers and the leadership team on the health IT side. And we've done a wide range of sort of implementing and going live on electronic health records from previously paper charts, and then looking at new systems, for example, for reviewing ophthalmology images, and looking at ways of leveraging all the data that are produced in the sort of course of routine clinical care and being able to use that for quality improvement projects as well as for research projects. And then a large part of my time is involved in doing research around health IT, in particular looking at different aspects of clinical workflows as it relates to health IT and the impacts on physician burnout and other outcomes.
Okay, thank you very much. You did mention that you did quite a bit of work about the transition from paper records to EHRs in your clinic. And you did quite a few research papers on that. What would you say were the most important things to come out of those papers? And if I were a private practice physician trying to make this shift now, what would you say I should focus on?
Yeah, so, I think that in terms of the transition from paper charts to EHRs, there were a lot of lessons learned. Certainly, there's both advantages and disadvantages to using EHRs for clinical documentation. The advantage, right, is having a digital record that can be shared across time and space for different doctors and now patients to be able to view and track the course of their care. I think that's been hugely powerful. The ability to have digital data that can be used for AI and predictive analytics, and to be able to apply that data, whether that's for population health monitoring, to be able to integrate sort of real-time clinical decision support based on that data. Those are all really powerful things. But in working with physicians as they make that transition, we have to realize that it is a difficult process to undergo change. And that especially in fields like ophthalmology, where we're doing a lot of drawings, that EHRs are not always well designed for that purpose, and that it just takes more time to document in EHRs. And so that's been well documented across all of medicine and also specifically in ophthalmology, that the time required to use these systems is greater than what was required on paper. But that being said, I think that the advantages still far outweigh the disadvantages, and that we are really, entering a new era of medicine, especially with AI and big data, and that electronic health records are a big part of enabling that. For somebody who is looking at the transition now, I would say they're probably few and far between now that EHRs have been widely adopted. But I would say, it's good to get engaged early on with your IT vendor, trying to be clear about your needs as a physician and what your workflows look like and how that might be best served by the EHR system you're working with. And that's been a key learning point for me, is that workflows are really key, and that sometimes, it's not necessarily the mode of documentation itself, but rather the interplay between that documentation system as well as, the physician and any support staff and the order of doing things, even the space, like where you have things set up in your clinic. All of those other elements are really important for efficiency as well. And so one of my IT collaborators used this analogy, which I really liked, which was, you're learning to dance, and you dance when you go from paper to EHRs. But not only, you have kind of maybe the same dance partners, right? Your technicians, your MAs, your nurses, your residents and fellows, but you're all learning new steps, and you're all learning it at the same time, if no one is sort of expert at it and been using it a long time. And so everyone's learning together, and just be patient with that process, and that it takes time. And I think, in clinical informatics, we do a lot of training around change management and how to manage expectations, try to keep lines of communication open, and that's an important process in terms of making a big transition like paper to EHR, and just understanding that it's going to take time to get used to a new system and a new way of doing things.
And I will note, you said that there aren't many physicians left, but my dad's physician is still using paper charts.
Yeah, I mean, even at a UCSD, we're a tertiary sort of academic medical center, and our ophthalmology department was using paper charts up until very recently as well. So yeah, you're right. I think there are people who are still using paper. I think ultimately that over the next couple of years, we'll probably see a complete transition to electronic health records, with the various federal regulations around sharing information with patients, and just with all the new digital health tools that are out there that leverage these data. I think that, that transition will be complete in the near future.
While we're on the topic of EHRs, one of the things that EHRs are always brought up in is the topic of burnout. Mm-hmm. The EHR is one of our favorite things to complain about. But what do we need to change about EHRs to help deal with physician burnout, nurse burnout, all of the medical practitioner burnout that's only worsened over the past couple of years?
Yeah, that's a great question. So I'll just start with, kind of what we know about EHRs and burnout. I mean, as I mentioned, one aspect is just the sheer time required, right? It just takes longer to document in EHRs than it does on paper. And that's been shown in many different studies. Part of it too is this idea of cognitive complexity, and the fact that people are sort of multitasking a lot in EHRs, that there are many different ways to accomplish the same function, that there's a lot of copy paste and ability to replicate information. And then what you get is something called note bloat, where the notes end up getting progressively longer and longer, and it's hard to find the information that you really need to distill down to, that's important for your decision making. And then I think there's also this idea of blurred boundaries, right? So before, when we had paper charts, you had to chart at your place of work, at your clinic, and that chart physically was located at that clinic. And nowadays with electronic charting and the ability to access things from home, it's kind of a double-edged sword. It allows you greater flexibility, but at the same time, it allows work to sort of, bleed into all aspects of your life. And it could be weekends or late at night, and you're still spending time charting during those hours because you can. So, there's a lot of work being done to better understand how we might improve our use of EHRs to combat this epidemic of burnout that we're seeing among healthcare providers. I think some of the things that seem very promising to me are, again, maybe not changes in EHR systems themselves, but this idea of team-based care, care coordination, having your support staff being able to prep orders or help with some documentation, or really allowing each person to fully contribute, and having, a lot of practices I've used advanced practice providers and like nurse practitioners or physician assistants to help out as well. And so this idea of team-based care, I think, is a very powerful one. It involves changing workflows, but I think it does is one way to mitigate burnout. The other thing is there's a lot of cool tools on the horizon, like, integrating voice dictation, and using that instead of typing, trying to improve interfaces so that you're not having to navigate across many different windows, but being able to see all the relevant information in one place. Our EHR vendor has a way of doing the documentation. So you're really just updating the assessment and plan and listing out the problems for, the diagnoses that you're seeing for that patient's visit, but not having to replicate all your exam findings in the progress note because it's already been captured in other parts of the chart. And so this idea of not having to copy everything into the note, but being able to just automatically pulling in some of that data, whether that's using shortcuts or macros or like these different tools for helping with the efficiency of note writing. So that's all an active area of research. And one of the cool things about some of the EHR systems is they have what's called audit log data that looks at how long people are spending on certain tasks that can show you, how much time was spent on documentation versus on writing orders versus managing the in-basket or the inbox of patient messages. And I think there's a whole vibrant area of research around how we might optimize these processes. So a lot of, I'm hopeful that there will be a lot of developments in the near future to help us, reduce the burnout associated with using EHRs.
You took care of the nation. It's time for the nation to take care of you. The AMA stood by America's physicians and patients during the pandemic, and we're not stopping there. We're fixing prior authorization, leading the charge on Medicare payment reform, supporting telehealth, fighting scope creep, and reducing physician burnout. It's time to rebuild, and the AMA is ready. To learn more about the AMA Recovery Plan for America's Physicians, go to ama-assn.org/time to rebuild.
So the question that we've all had on our mind for the past I don't know how long it's been. How has COVID impacted your work?
Yeah. So obviously COVID has had far-reaching effects into, all segments of society and so many different aspects of our lives. From the standpoint of as a practicing clinician, we certainly saw our visit volume go down, and then now it's really just a lot of pent-up demand, and we're trying to keep up pace with all the patients who want to be seen. But at the same time, I think COVID really opened up some opportunities around telemedicine, which was not widely adopted prior to the pandemic, and really saw an explosion in adoption during the pandemic, in part out of necessity from the various lockdown restrictions. And I think some of that change will be here to stay. In ophthalmology, we've found ways to do telemedicine visits, both, in terms of synchronous video visits, as well as asynchronous sort of store and forward type, imaging interpretation. And one of the things that I worked on during the pandemic was setting up a program to screen for diabetic retinopathy using cameras at primary care clinics, so that patients with diabetes could get their eyes screened while they're at the primary care doctor instead of having to make a separate trip to the ophthalmologist. And this increased our screening capacity by quite a bit. I would say the other thing about COVID that has really influenced my work is just the fact that it highlighted so many health disparities that, predated the pandemic, but maybe didn't receive quite as much attention and really was highlighted during the COVID pandemic. And I've been very lucky to work with the NIH All of Us research program, which is a nationwide research study with a specific emphasis on enrolling patients or enrolling individuals or participants from traditionally underrepresented groups. And that's been a great opportunity to better examine health disparities and understand ways that we might be able to improve and do better for people of all backgrounds. So for me personally, that's been another thing that's come out of COVID and has really influenced a lot of the research that I have pursued in the interim. From a health IT perspective, our university has done a lot around COVID, directly, whether that's setting up mass vaccination clinics, setting up our entire sort of vaccination and booster infrastructure, testing infrastructure. All of that is so dependent on health IT infrastructure and doing, various builds to make it easy to, set up testing and vaccination at a very large scale. So I think, for the medical students out there listening, that's one thing to keep in mind about how health IT really touches so much and really underlies so much of what we do in a health system. And so it's a really neat opportunity to make a difference on health outcomes, and COVID just being one example, but that was a very clear example of where health IT was critical for us to be able to help address the challenges of the pandemic.
That's great. And I did want to just highlight the work that you do with the underrepresented minorities. You and I are both a part of those groups, and it's really something that I feel like we're both passionate about. On the whole, how do you see ophthalmologists integrating these new changes into their practices that have been brought on by the pandemic? And what do you think can make the field more receptive to these changes moving forward?
Yeah, so for ophthalmology specifically, I would say that there is definitely an interest in further expanding telemedicine. And like I said, there's different forms that takes, like including synchronous video visits, but also some of this idea of remote patient monitoring and people being able to do monitoring at home. And I think there's a lot of interest in that in the ophthalmology community. And it still remains to be seen, how much of it sticks in the sort of post-pandemic era. And concerning the other thing I talked about in terms of health disparities, I think the ophthalmology community has really embraced that. The American Academy of Ophthalmology, which is our national specialty society, has a series of books called the Basic Science and Clinical Series that is sort of the de facto curriculum that every, ophthalmology resident and physician who's going up for recertification has to study and read and know inside and out in order to become board certified in ophthalmology. And this year they added an entire section on social determinants of health and health disparities. And there's a lot of work at the national level to understand, how we can better study health disparities and better tackle health disparities. And one aspect of that was, how do we leverage data? How do we look at, EHRs and other data sources to help us with this very important problem? And also, what are some of the digital health technologies and, other approaches that we could use to help mitigate these disparities? So certainly something at like the national level that is of interest and has really gained a lot of steam after COVID. And so I'm really excited to see that. And it's also something where I think health IT will have a big role in, whether that's, helping to analyze and obtain the data for understanding the problem, and then also in informing the potential solutions.
And we've kind of touched on this a bit, but how specifically do you think that telemedicine is going to work with ophthalmology? Like, you can't take a slit lamp and look into a camera and look at a patient's eyes. So what are the things that we're going to have to bring to bear to fix these issues with visualization and getting that data?
Sure. Yeah. So I think technology is going to play a huge part in that. There are, there are some subspecialties of ophthalmology where you can get a lot of information without a slit lamp exam. And some examples where that's done really well is in, oculoplastics, as well as neuro-ophthalmology. Our pediatric ophthalmology and strabismus colleagues have found ways to do parts of the strabismus exam over video, over Zoom. And there are mobile apps that you can do that actually measure people's eye movements and format them, beautifully and more, you can get this photo montage that looks even better than sometimes what we've done in clinic before. So certainly there's some specialties where they can do a lot over just video. But you're right. So much of ophthalmology is dependent on our physical exam. And, it's hard to do that over Zoom. And so I think there's going to be a big role for technology for people to be able to do some of that at home. And one area would be in terms of imaging. So there's been, an explosion of different imaging devices that can attach to smartphones, for example, and image your retina and optic nerve. And then, there's home-based intraocular pressure or eye pressure monitors that can help for glaucoma monitoring, for example. We have a number of imaging devices that are really important for monitoring a variety of diseases, including diabetic retinopathy and macular degeneration, called OCT. And while traditionally that's been a desktop camera that we have in the clinic, there are a number of prototypes out there of handheld OCTs or mobile OCTs that are being used, that could theoretically be used at home or in sort of satellite clinics to improve access to care. So there's a lot of exciting developments. I think technology is going to be a big part of that, to acquire the data that we need to help manage our patients. And then certainly from the informatics side, we have to think about how we are going to integrate that data in all those devices with our electronic health records, our PACS, which is, picture archiving and communication systems, which is how we review images, and sort of all of our clinical information systems that are currently in practice. So that integration piece is going to be really important.
And I did just want to highlight, I did not know about the strabismus thing. If you've seen someone actually do a child ophthalmology exam, it's hard to do that in person, let alone over the camera with a 2-year-old trying to keep their attention.
Yeah, it's called the 9Gaze app, and it has, either a light or some kind of target for the person to look at, and they have them follow the target and get their eyes in different gazes. And then it makes a beautiful photo montage that shows the person's eye movements. So I thought that was a pretty neat thing.
Yeah, I've been in clinic trying to do that, and that is not an easy job to get done.
Yeah.
As a future physician, how do you see the future of health IT in 10 to 15 years when I'm practicing, full-fledged ophthalmologist or radiologist or whatever it is I become?
Yeah. So I think right now it's such an exciting time to be in medical school. And learning about not only clinical medicine, but also, health IT and all of these different technologies. When I was in medical school, I didn't even know the term informatics, I think, until I don't know, maybe a month before I graduated. I took an elective, but it just wasn't at the forefront of our curriculum back then. And there's so much promise and potential for really revolutionizing the way that we deliver healthcare, and in terms of our ability to impact patient outcomes through health IT, through digital health, through AI. And, is there a lot of hype? Yeah, sure, there's a lot of hype, but I think there's also a lot of real improvement to, how we're doing healthcare because of health IT and because of the technology infrastructure that we have available now. And so as a medical student, being able to learn that and understand that at an early stage really puts you in a great position to then try to lead the field in the future. So I think in many ways, informatics and understanding information technology is going to be, I think, a core part of being a physician 15, 20 years down the road, if not already. So certainly, I think as if you're a medical student or a resident or fellow, this is a great time to learn about health IT, to get to know, some of the IT teams at your medical school, at your institution, and, maybe look into projects and how you can help. There's so many areas where health IT has made a difference, and it always helps to have people who can sort of speak both languages, right? Like understand the IT side and understand the clinical needs. And that'll really help, I think, really make a high impact change on the areas of greatest need. It's a very exciting time. I just say, keep up your enthusiasm, keep up your interest, and don't be afraid to learn new things. I mean, this field is changing so quickly that I think that's one of the biggest challenges, is just trying to keep abreast of everything. But don't be intimidated by that. Like it is both a challenge and also a really exciting part of it.
Finally, do you have any channels where people can connect with you and follow your work?
So I'm on Twitter, Sally Lou Baxter, SallyLouBaxter. Our lab website, which honestly I'm ashamed to say I don't update as regularly as I should, is baxter.ucsd.edu. I think probably email is the easiest way to get into contact with me, and I'm happy to answer any questions that any listeners out there might have. So that's S as in Sally, the number 1, Baxter, Baxter, at health.ucsd.edu.
Well, everyone, that's all for today. Thank you for listening, and thank you for your time today, Dr. Baxter. This has been Making the Rounds, a podcast by the American Medical Association. You can subscribe to Making the Rounds and other great AMA podcasts wherever you listen to yours, or visit ama-assn.org/podcast. Thank you for listening.
Thanks so much.